Thank you very much for these flattering words. And it's a real pleasure to be in Cairo. I was in Alexandria two and a half years ago, just a week before the COVID really attacked us, and it's a great honor to be with you, the Vascular Society of Egypt. I was invited to address some issues for the future, and I watched the logo and let's say the leading terms of this meeting being patient safety and innovation. And that's why I will address in the next 20 minutes our, let's say, daily activities from some different perspectives rather than showing you 20 videos on thoracoabdominal aortic aneurysms. So please forgive me that I try to approach this subject from different perspectives, but it's also, for my personal experience, a new experience, because I started to discover that this is just opening the end of my career, and it allows me to give different perspectives on the whole subject than I did during the last 30 years. What were the main activities in vascular surgery and innovations over time? When we look at, for example, deep venous obstruction, for the last 30 years, patients have been receiving stockings, having huge ulcerations, etc. But since 10 years, reconstruction and recanalization has dramatically changed the care in these patients. The same for peripheral arterial occlusive disease. In my time, when I was trained, there was bypass surgery, or amputation. But this whole development of the most high-tech endovascular techniques, now even going retrogradely through pedal arteries, is an innovation in vascular surgery. And of course, the whole change from open to endovascular solution. It's evident, it's an open door, everybody is familiar with it. But when I trained 30 years ago, all these were not applicable or didn't even exist, like MR, PTA, stenting, embolization, thrombolysis, EVAR, TEVAR. We now take it for granted, but these have been real innovations in our daily practice. There are, however, things like these which already play a role since 20 years but have not established yet. And I know there will be other presentations on robotics and issues which are mentioned here, but we are already doing research in the world on stem cell implantation, tissue engineering, nanotechnology, etc., but it has not reached the level of implementation yet, maybe. Now, let me touch some words on thoracoabdominal aortic aneurysms, because there we went through a very interesting phase, of course. The icons, as indicated here, with Volodos, with Parodi, of course, Roy Greenberg, bringing complete open surgery to complete endovascular solutions. And what will happen in the next 20 years is open for discussion, and I will just spend a couple of words on this. Because what are the left indications for open thoracoabdominal repair? Well, in my mind, in our practice, when there are no endovascular options, very clear. If we have young patients with connective tissue disease, and the last group, which is growing rapidly, really, is secondary interventions after TEVAR. And what does that mean? Well, that means a long list. Patients with endoleaks, type 1A, 1B, where there is no endovascular solution, progression of the disease with growing aneurysms despite adequate TEVARs, endograft infection, and even worse, aortobronchial fistula or aortoesophageal fistula. So this is a real significant group of sick patients, and open surgery, unfortunately, is still the only solution. Here you look at a patient with Marfan syndrome who got a TEVAR, and this is what happens 2 years later. It just eroded through the aortic wall, causing an aortobronchial fistula. And the procedure is a pretty large procedure, and it looks horrible. It's the only video I show you, so don't worry. So here we are with the thoracotomy in an infected graft, lying in the pus, And the only solution in this case is remove the entire endovascular stent graft in this case, and then replace the descending aorta with bovine pericardial tube grafts or with a polyester graft soaked in antibiotics. But if we are obliged to do open surgery, I'm convinced that there should be a systematic, complete infrastructure organized protocol to protect the spinal cord, the brain, the heart, the liver, the kidneys, the intestines, the peripheral arteries. And that can only be done if you have a strict protocol, including extracorporeal circulation, selective organ perfusion, custodial protection of the kidneys. If the arch is involved, cardiac arrest, antegrade brain perfusion, CSF drainage, and monitoring of the spinal cord function. Without such a protocol, results will be not good enough. We have touched on that many, many times. I'm not going to discuss the details of the results, but my worry is, what about the future? Because first of all, the generation following us is not prepared, not willing to invest time to learn this complex surgery. So for the moment, centralization of care is an absolutely must. But maybe even more important, centralization of training should be centralized to get the knowledge under one roof and at least a chance to train our next generation. Now, I've been digging into business development plans in the medical industry, in the plans of researchers, in the plans of Wall Street, whatever, just to get a short summary of the main technology and the innovations foreseen for the next 10 years. And to my surprise, there is nanotechnology back again. So there is now really, it's interesting if you read the literature, a change from science fiction to science and actually implementation. I touch on that in a second. The same accounts for internalizing diagnostic and therapeutic devices. I will address what this means in practice. And finally, which will be an enormous innovation, of course, is 3D organ printing, which is no science fiction anymore, but it's getting really to practical implementation. So these pictures are known for 20 years, but now it's really proven in studies that the mini robotic systems will be able to restructure, to rebuild, to clean up, etc. It is even shown now in animal studies that DNA reconstructions can be performed by programmed nanotechnology instruments. It's scary, but it's happening. And it's expected that within 10 years, the first implementations in clinical practice will take place. This is an image which is not new in such a way. We know that the internalizing of diagnostic and therapeutic devices increasingly are taking place, where of course remote monitoring will be possible, remote treatment will be possible, but this will dramatically extend towards a situation that the patient is not even coming into the clinic anymore and is just surveyed through satellites or whatever systems to control the situation, to intervene if necessary, and only calling the patient into the clinic if necessary. And this will also really apply to our cardiovascular patients. Some words on this 3D printing of organs. The liver was one of the first organs where the 3D printing was tried, but also executed. But more interesting now is the same technology in 3D printing of the heart. And of course, a heart is easily printed in 3D, but then you need a functional heart. A functional heart with coronaries, with a myocardium which is pumping and contracting, and valves which function in a decent way. But this technology is determining our future, because it's amazing what nowadays can be done with stem cells. They can be programmed, they can be instructed and they can differentiate towards cardiomyocytes, smooth muscle cells, endothelial cells, etc., all with a specific program to become functional in the way we would like to do so. And this combination of 3D printing plus the whole cell programming will eventually lead to functional hearts, to functional blood vessels, and etc. Once again, sounds like science fiction, it's getting close. Decalcification of arteries, it was just a fiction 20 years ago. Why don't we have a little fluid we drink and we clean up all our arteries and we don't have to operate anymore at all? Decalcification of arteries with programmed macrophages is proven to be feasible. And you see this green macrophage running through a calcified plaque, just destroying into small pieces, clean it up, and in animal studies, clean up arteries indeed. So the moonshot, actually, before we go to heart transplant, because there will not be enough hearts available for transplant, is that a diseased heart is taken out of the patient for a week. The patient is on ECMO or extracorporeal circulation whatsoever, and the diseased heart is treated first with the programmed stem cells, which have been created to be active myocytes and inducing the myocardial function. The arteries are cleaned up, the valves are cleaned up, and a week later, the regenerated heart is put back into the patient and will start living again for the next 20, 30 years. Sounds crazy? It's close. But what does this all mean? Because we are threatened by totally different issues, daily practice. The costs are so excessive, the budgets are not covering it, innovations are incredibly expensive. Result is that healthcare is not accessible for everybody anymore. So how do we get out of this split leg position? That's the future, not only of cardiovascular, but also of healthcare in total. So the costs are exponentially growing, and here it's a simple summary of the personal determinants, the unnecessary treatment we are performing every day, and the prices as we experience every day rising exponentially as well. So there must be methods to control this uncontrollable cost environment. Books have been written. We have been working the last 10 years in trying to get the best way of assessment of the cost, assessment of the outcome, and we have started to work with the so-called value-based healthcare system 10 years ago, where it's of course it's a theoretical term, but value-based healthcare means that the value is determined by the equation of health outcome for the patient divided by the costs. Very simple. But the execution in practice is rather difficult because it requires that all outcomes, whether clinical outcomes, complications, long-term results, but also the proms and the prems are taken in this equation, and that in the cost, everything is included as well, like consultations, diagnostics, lengths of stay, ICU, operating capacity, materials, etc., etc. But at the end, it brings to you the value for the patient, the cost, and you can decide on the strategy how to decrease the cost or how to improve the outcome, etc., etc. Because at the end of the day, what value-based healthcare should do is accomplish the same clinical outcome with less resources or get better outcome with similar resources. It's a kind of simple approach, but in this cost effectiveness discussion, this will lead the future. And as last subject in this discussion, I touch on something I've been really intrigued by during the last 2 years, is the elimination of the unnecessary. unnecessary care. What does it mean? If you open up the literature, if you go to the internet, you are overwhelmed by the analyses of healthcare expenses and the harms of overusing, overtreating. This is an analysis already 10 years old, where a very deep research showed that in the United States, on an annual basis, I mean, it's shivering numbers, $750 billion are wasted with unnecessary care. That's the same money as the total Iraq war in the United States costed. And this is an annually coming back amount of money. And yet, imagine how much research we could perform with this budget. And it's all about not unnecessary care. And they analyzed that unnecessary services accounted for 200 billion, and still, inefficient delivery of care, etc., etc. So we have to change our policy. Does it apply for vascular surgery as well? Well, of course. If we critically look at the carotid, and that's why the previous discussion was so perfect, or our peripheral arterial interventions, or our aneurysm treatment, our venous interventions, varicose veins, etc., are all these procedures we perform necessary? Well, it has been proven that at least 30% is totally unnecessary. And not only in the US, also in Egypt, also in the Netherlands, also in every country, which of course is very explainable because we are surgeons and we are taught to do so. But the mindset needs refreshment. Take an infrarenal AAA. I mean, we know that the threshold for intervention is 5.5 centimeters. The annual risk rupture is like 3.5%. So if we take 100 patients having an aneurysm of 5.5, we treat them all 100 of them. But that means that we are over-treating 96 of them. The problem, however, is we don't know which factors influence the growth or determine rupture. We have no markers available to predict growth, no markers available to predict rupture. So there is only one solution to avoid 96% overtreatment, is that we invest in research to identify very reliable markers predicting growth and risk of rupture. Is that fiction? No, it should not be. It should be reality, because we are overtreating 96%. I made a deep dive in literature, and you see many, many, many publications on biomarkers. Conclusion, this might be a predictive important biomarker, but further research has to be performed. In other words, we don't have a solution yet. And the same accounts, and we did this research as well, is with very intelligent modeling of shear stress, wall stress, etc. Try to find predictive markers in aneurysm rupture, but so far this has been totally unsuccessful. A new approach, and that's really future science, is to integrate and combine preoperative assessment, intraoperative assessment with the same criteria as wall stress, shear stress, etc., but combine that with blood and tissue assessment in a biobank, etc., where artificial intelligence will jump in trying to identify predictive models in patients with aneurysms. Otherwise, we keep on treating patients with unnecessary operations. But also, I guess, in the future, the mindset of talking to our patients should be adapted simultaneously with which I just mentioned. Because if you have a 49-year female in front of you with a 5.5 centimeter, you can either have a discussion that, wow, lady, you have a large aneurysm, you have a ticking bomb in your abdomen, you are at very great risk, and there is only one solution: surgery. Versus, You have an aortic dilatation, but you don't have to worry at this moment. We will survey you. The risk of rupture is low, it's around 3-4%. And surgery is an option, but we have time. So that's a 180-degree different approach. So this mindset switch from left to right, where you focus on this 4% risk versus focusing on 96%, nothing will happen, is something in our mindset which is rather difficult to accept and to introduce. So, in summary, it's a different approach than showing surgical techniques and surgical innovations, but I just wanted to summarize what is happening in research world around us. And it's amazing to see how far researchers have developed all this, and application and implementation is not far. Well, not far, but within 10 years we will have a totally different discussion in this room. So if I would wrap up, future healthcare faces increasing costs, higher demands, also from the patients, more and more complex pathology, expensive technology, and aging population. So the problem will increase and increase, so we have to be ready with solutions. Healthcare budgets will never ever rise accordingly to the costs anymore. And it's crucial in every field, whether it's cardiovascular, oncology, psychiatry, whatever, we have to develop markers and define parameters much more in detail to treat in the most efficient way and avoid, as much as possible, unnecessary care. And the most important, but that's more an ethical issue, of course, is the challenge to offer healthcare, and it should be accessible, it should be affordable, and best quality for everybody. Thank you very much.
Thank you very much, Professor Jacob, for this great talk. And we can receive one or two questions from the audience. First, I have a question for you, Professor. After COVID-19, is there any change in your thought about the future of vascular surgery during the next few days or few years?
Well, that's a very difficult question, but also interesting, because there has been many publications on the phase during and after COVID. If I look at our personal practice, patients didn't dare to come to the hospital. We had significant lower ruptures, significant lower dissections, significant lower myocardial infarctions, not because of something changing within the patient group, but just they didn't come to the hospital. But we have never heard complaint from family, etc., in a way that if COVID would not have existed, my father or my brother would have been alive still. But it also showed that natural history suddenly had a place in society, which is very, very strange for us, that patients do not come to the hospital because of COVID. This does not really answer your question, but this was the experience we had in our center, that by COVID, natural history showed what was going on, and it's pretty scary.
Okay, thank you. Please, Dr. 𝗏𝗏𝗏𝗀.
Thank you for the lecture, Professor Jacobs. I feel exactly the same, that we're over-treating patients with aortic aneurysms and claudication, etc., etc. And sometimes it causes harm to them because few of these will not make it through the treatment. But some Unfortunately, we need to direct some of our resources not just towards treatment, towards prevention. For patients to continue to smoke and be overweight and not do exercise, they come to us in a very poor state. Perhaps if some of our resources is directed towards prevention, we will have less of all of this. How do you feel about that?
Well, I agree, but so far preventive medicine is rather limited. What are we doing with preventive medicine? We check blood pressure, we stop smoking or advise to stop smoking, we take care of obesity, diabetes, etc. But it's not really taking care of the basics of the problem. And we don't put consequences if patients do not follow this preventive medicine. We will never say the patient, well, I'm not going to operate on you because you are obese or you didn't manage, etc. So we don't have a balance yet, and preventive medicine has to go much deeper than we currently do.
I didn't suggest we don't treat them. I think we should treat them.
Sure.
But in England, for example, the number of peripheral arterial cases is dropping because they don't smoke. So we must try to emphasize the value of that to the patients.
I fully agree. Yes.
Professor Ahmed?
Hi. I agree with Dr. Hindawi. The willingness to pay threshold for communities need to be reset after the COVID issue. And if it's set for $150,000 per quality adjusted life year in the US in the 80s, or by it's might have changed. And the other thing is that there are many pressures, whether financial, ethical, and patient pressure. Let me give an example. We are enrolling in the CREST-2, and this includes intense medical management versus intense medical management and intervention. Most of my patients randomized to intense medical management, they come and withdraw from the study and want an intervention. So, and I have to offer it.
Yeah. I fully agree.
Professor Naylor?
Mike, I mean, I really enjoyed your lecture. You know, you and I have very similar thinking on much of this. But siren voices, and I've learned this over the last 10, 15, siren voices rarely make a difference. The medical industrial complex is so powerful, and the politicians are almost scared to engage. How do you really embrace the concept of what you're proposing? You know, how do you tell the American government or whoever that they're wasting $750 billion 10 years ago? God knows what it is now. How do you do that?
Well, I try to make clear that without very strong markers, evidence that you can identify those who need and those who do not need, that you might break this vicious circle. I mean, the biggest group of patients having unnecessary treatment in the US are orthopedics, like hip replacement, knee replacement, etc. If you point at your knee and say, oof, I have a painful knee, within a week you have a new knee. Why? So if we could work, and that will take a long time, on reliable parameters, reliable criteria dictating to the left operation, to the right conservative, that would help. But I fully agree that it's like in the tobacco industry. We all know that you die from it, but countries survive because of the high tax incomes. So these split positions will remain for the next couple of 100 years, I guess.
Professor Samer?
Thank you for the presentation. Really enjoyed it. I think the main reason for the very expensive, practice we do it is a defense medicine. This is where the cost is. Patient comes to the ER with a headache. If you don't do a CAT scan and then later on you find he has intracranial bleeding or tumor, you'll be reliable for that. So how we can draw the line between defense medicine and expenses? This is a society rule to do that? Is it, how we can protect yourself? Because all the expenses done because physicians want to protect themselves from lawsuit or something like that. Because if you don't do everything, like just like 5.5 centimeter aneurysm, I'm really convinced that 4% is not very high risk. But if you don't do a surgery and patient rupture, then it will be reliable for that. So I think the society or the government should do something different, or what do you think?
No, but you know, I don't disagree. I mean, if you send a patient with 5.5 centimeters back home and ruptures next week, you are in trouble. I fully agree. I think the responsibility should be with the profession and not with the government or other instruments. But my only plea is to have research focusing on predictors so that we stop over-treating them, because I think you agree that we are over-treating at least half of them. So it's difficult, but you have to start with a different mindset, otherwise we just keep on going for the next 100 years in the same way.
But I think we need the help from the society, or who publish all these guidelines, to help us, to maybe lower the threshold for treatment so we can lower the expenses, because you need some kind of defense, when you
agree.
practice. Yeah.
But if tomorrow I would have the possibility to talk to Mr. Biden, and I say, Mr. Biden, we could save $700 billion, do you give me a chance? And I ask, just give me 1%, that's enough, personally, then I do my best. I mean, it's also the acceptance, obviously, in politics, that $700 billion is okay.
Thank you.
2 more questions, please. Professor Omar?
Yeah, I enjoyed your lecture, and I enjoyed actually my visit to your wonderful center. But I think the cost of vascular service will increase in the future, because based on what you said and inspiring it, I think in the future the preoperative management will not just be control of hypertension and diabetes. We may in the future send the patient for preoperative shockwave, extracorporeal shockwave rice for calcification, to control calcification, or for genetic therapy, and then send the patient to hybrid room to do a combined surgery and endovascular surgery. So the cost will be increased, and we have to find a solution for this.
Yeah, but I agree that the cost will increase is inevitable, because innovation is expensive. Yeah. But if you can reduce 50% of them because they don't need it, it's costing more per patient, but it will reduce the total costs. So my only plea is those who don't necessarily need it, just don't do it. But those who need it, follow your strategy. Fully agree.
Last but not least, Professor Sharif Sultan.
Tell me, you are the boss in your department, or you think you're the boss like myself and have no power at all. How do you deal with naughty people in your department who decide to do non-indicated intervention and then they do harm? How could you deal with that? Because you have said it and you have nailed the whole nail in the whole situation is do no harm, and they do harm. And how to tell the patient, avoid doctors, they're bad news. How do you deal with that? Because it's becoming a huge problem, and a lot of people forget about governors and doing a lot of things that harm the patient in the short, mid-term, and the long run. How do you deal with that currently?
Yeah, well, maybe for tonight, when we have a drink, we can discuss that, Sheriff. but it's, the French say, frappez toujours. Hit and keep on hitting. Every time ask the question, why did you do it? What was the reason? What was the indication? What was the outcome? What was the evidence? I know it's very difficult, but you have to start somewhere. And of course, we are trained, and training is still like that as we function. But we have to be able to adapt our structure in a way as we discuss here. And of course, I mean, when I look in my hospital where we need more physicians because work is getting more complex, etc., I get 0 budget. But around me, they just appointed 25 new directors in finance, in supportive medicine, in capacity management, in etc., etc. So the discrepancy in the bureaucracy is rather painful. So we have a long way to go. I do realize that.
Thank you.
Thank you very much, Professor Jacob, for this very interesting session. Thank you very much.